Hi everyone, welcome to Exercise Prescriptor. This team discussion is all about how exercise helps to reduce the pain. So we all know 20 years before to reduce the pain we use modalities, and 15 years before people are started approaching taping techniques. 10 years before we all started using myofascial release, soft tissue release, this kind of techniques and all come into the picture. And recently, 5 years before and recently people are going behind dry needling and cupping. So every 10 years for next 10 years once everything is going to change to reduce the pain. This keep on change, but when you apply dry needling, taping, IFT, whatever, releasing, but at the end they suggested to move your body. If you move your body, you can get a full recovery. So always in your clinic patient comes and approach with only two problem: either I have pain, I couldn't able to move, or else I couldn't able to move because of pain in musculoskeletal practice. So considering this is a major factor, how movements helps to reduce the pain, this is what we are going to discuss today. Come on, let's get dive into the video. So what do you people think, how movements helps to reduce the pain?
For example, if we do exercise, some people because of exercise pain will decrease, but some people after exercise they'll get the pain will get increased more sometimes. So it's not about what exercise you are doing, it's all about the way how you usually use that exercise.
Oh.
For example, if you are I'm having any back pain, so I'm seeing YouTube videos, I'm doing exercise, but some patients the exercise will work, the pain will get reduced, but some patient the YouTube video doesn't work, they won't get better.
Why what was the reason?
And the cause is different.
Cause is different.
Yeah.
Okay, which
Um,
means
which means if the patient have a maybe load induced pain. Okay. So they're doing only for mobility workout in YouTube video. So they're doing. So some patients have mobility restriction. They only doing the all the strength and they don't know about the which factor we affected.
exactly.
Yeah.
Basically you're trying to say here the patient needs and demands will be different, and the cause of the problem may be different.
And
So,
each and every individual are different.
individual are different. Even though if we treated 100 people with the same diagnosis, we can't prescribe same movements to all the patients. So what was the problem? So in our clinical practice, in our physiotherapy practice, usually people are worried to give exercise. I am saying that's the biggest reason why they are not giving exercise or movements in initial when the patient has pain. Because what if the exercise or movements aggravates the pain? So what is your answer for that?
So, what to say? First of all, the physios no need to get fear of aggravating the pain. We need to ask the patient before doing the exercise and after doing the exercise. If the pain intensity was same, we need to just do the movement. If it was too less than acceptable level, we need to increase the intensity of the exercise. When it was too much high, then only we need to reduce the intensity of the exercise and do the movement.
Okay.
As he mentioned, we can modify the dosage and we can also educate the patient. Maybe since it's the first time you are trying to move, which you have not moved for a long time, it might slightly increase the pain. Because we are educating the same way for dry needling or
Beautiful.
myofascial release or anything. So
Excellent.
we can educate them. If they feel, for example, pain is more subjective according to them. So according to their pain threshold, we make sure that pain doesn't flare up and give exercise according to them, which is needed according to their needs and demands.
Basically, you're trying to say is when you do put dry needling also, next day you have pain. When you do soft tissue or myofascial also, you will get next day pain. But why you are biased with exercise or movement? Okay, because I feel honestly we don't know how to prescribe very accurately according to the person, because no one can able to prescribe the exercise apart from physiotherapist. Pathologists can't, radiologists can't. Physiotherapists can prescribe exercise. We are not doing that. That is a major reason. Okay, very good. And what's pain according to you?
To answer your question, it's really difficult actually because the pain is very subjective. For the pain of mine is not the same pain of Vikrant. So each and everyone will, the perseverance of pain is different. The perception towards pain is totally different. So actually, when it comes to patient, it's a highly what they think about pain is matters more. Like for them, for few people, running will cause pain. For people, even walking will cause pain. It doesn't mean the walking is the activity doesn't matter here. According to the patient lifestyle and how they work out, what is the physical activity status of them, according to that only, even walking is an high intensity for few people. So running is high intensity for few people.
So what you perceived actually pain. It's a
Yes.
pain for you. Even though walking causes pain for all 10 people's, all 10 people's pain intensity will be not the same.
Yes, exactly.
Differs.
Yes.
So what
yes.
you perceive is pain is pain.
Yes.
So understanding the perseverance is plays crucial role in prescribing the movement.
Yes, of course.
So that's why if the patient have the pain, two patients come to us, the patient have the 10 out of pain. So some
10 out of 10 pain.
10 out of 10 pain. So other patient have the 7 out of 10 pain. So 10 out of 10 pain. If complaint is back pain, if we're giving the Jefferson curve, they're ready to do.
Maybe they can able to
They
perform.
perform.
Yeah.
They're ready to do. Maybe the 7 out of 10 pain, the same exercise if we give the moderate pain, even though the moderate pain he have, so if we give the exercise to them, they can't ready to perform.
Highly
So
excellent point.
because the self efficacy is different. The self efficacy is different, and the fear avoidance is between two people is different. Fear of avoidance. The intensity, the matters third point. So we the nowadays we perform the 10 out of 10 pain. How they treat the 10 out of 10 pain nowadays we. So no need to, not no need. So maybe that is a third point. So first one is the self efficacy. So second one is the fear avoidance, how they fear avoidance behavior. How they develop their fear avoidance behavior. The pain mean pain period. So third point is intensity.
Excellent. Yes. So basically, one person have 10 out of 10 pain, one person have 5 out of 5 pain, 5 out of 10 pain, and giving same exercise, maybe 10 out of 10 pain can perform.
Yes.
5 out of can't perform. The pain intensity is not determining the movement here. The person's self-efficacy determining the movement and fear avoidance determining the movement. Beautiful point. Excellent.
I like to add one point, like the exercise can be lead to habituation or sensitization. So it can also have negative effect, whereas the desensitization should take place. It takes time. So make it as an habituation to have a positive feedback and positive attitude towards exercise. Everything, it takes time. But exercise can be sensitization also. It can have negative feedback also, but it takes time to reach the habituation level, I guess.
So why we have reached competition? What does that mean actually to audience?
Habituation. So habituation means we are desensitization to the particular movement through repeated stimulus. Repeatedly for long period of time we are giving the stimulus again and again.
So basically, we can say in that terminology, the back pain patient couldn't able to bend forward. Graded exposure to the same movement with the lumbar flexion and different variation. So reintroducing the same movement may initially cause pain.
Hey, yo, the pizza here.
Sensitization of the pain. Then slowly that make an as a habitual, the patient fear will get reduced, so can bend forward.
Yes.
So exercise will really work for the pain, but we need to know what makes it work
Okay.
actually. So there are many ways to make the exercise work. One is, if you do exercise, some physiological changes may happen. So like that, if they're having any muscle tear, if you are giving any exercise, the tear got healed. So biologically, the exercise is working.
Oh, great.
So one thing. Second thing, psychologically. Some patients will have the negative beliefs regarding movement or exercise,
They will
something.
not have biomechanical problem to restrict their movement.
Yes.
Yeah.
So they won't actually having the tissue damage inside. Instead, they'll have some psychological fear regarding the negative beliefs, posture, pain, movement, anything.
If I move, my pain will increase.
Yes. So if we give exercise, meaningful exercise, definitely psychologically the patient will get better. So pain will get reduced. Third thing, biomechanically. If you are actually addressing the root cause, any loading, unloading, or any other lack of strength, the person is getting pain. If you are addressing, you are increasing the strength, or if you are correcting the mobility, so biomechanically the patient will get better because of exercise. And fourth one will be the descending inhibition. Like if you are giving any exercise or any movement, definitely the descending pain pathway will get activated. So pain sensitization or pain pathway will get activated, descending pathway. So pain will be better. So pain will decrease. Then last one will be the inflammatory reaction or immune system reaction. If you're actually exposed to any bacteria or something, your immune system, inflammatory reaction, everything will improve. Like it will get activated. Like the same way, if you're exposure to exercise, if you're exposure to any bacteria, like the same way, if you're exposure to exercise, same the immune system, inflammatory cells, everything will get exposure to that physical activity. So some anti-inflammatory things also will get stimulated because of exercise. So all these things are the major five things.
Can we recollect quickly? First one,
Physiological or biological cause. Second one will be the psychological factor.
psychological benefit,
Third one, biomechanical.
biomechanical,
Fourth one, descending inhibition of pain.
pain inhibition,
Pain inhibition. And fifth one will be the inflammation. Fifth one will be the inflammation.
fifth one will be the inflammation.
Yes.
Inflammation pathway to reduce the
For example, if the reason for the pain is inflammation, it is an inflammatory pain means exercise will reduce the inflammation, so patient will get better. So all these five systems won't work for everyone. Any one will work. So we need to find out which system we need to activate for them.
again it depends on the patient.
Yes. So usually we can say effect of exercise is non-specific, but it is specific to that person.
Okay, effect of exercise is not
Generally, it's non-specific. There are lots of behind lots of mechanism to heal the pain. So effect of exercise is non-specific, but it is specific to that person. So we need to identify what is the specific factor to that person.
As she mentioned, immune system will improve. I want to add on a point. As we start doing exercise, even for pain, if we continue it for over a period of 5 to 6 weeks, our body will get adapted to it, and it will become as anti-inflammatory immune system. So that our body is our own anti-inflammatory mechanism. So we don't need any anti-inflammatory drugs or anything to have.
So we were seeing now recently successfully the patients with ankylosing spondylitis, rheumatoid arthritis, weaning from it over the period of time. It was taking 5 to 6 years for them. I have seen recently a couple of people with very disciplined to sleep, very disciplined to movement and exercises, very disciplined to eating habit. When they take a blood test, so all the values are coming back to normal range. Medications are not taking, they are pain free, symptom free, aggravation free, relieving factor, there's no specific, so their lifestyle will be changed completely, they're completely slowly weaning from that.
What I also want to add upon is how exercise helps in pain, but I feel exercise is one of the part which help in pain and functional activity. But apart from it, as you mentioned, your sleep, nutrition, water intake, these also play a major role to help us become better, functionally more able.
Tissue damage takes place if the patient have any injury. So that time also we give the exercises. So when the ankylosing spondylitis, that time the inflammatory process is more high. Okay. That time also we give exercises. Okay. So in both conditions we giving exercise. What is the reason of this? That time the exercises helps in the pro-inflammatory. One of the time it helps in the anti-inflammatory.
Which time is anti-inflammatory?
That is a regulation of inflammatory process. That is the exercise's main thing. Because the cytokinin level, when it's increased, so that time it's come to the neutral level. When it's a decrease, and it's maintain its normal level. So when one patient, it's on a sedentary lifestyle, the one patient in is a very good and active lifestyle. So that patient, both patients get ankylosing spondylitis. So sedentary lifestyle patient can't overcome the anti-inflammatory process. But the normal active person, right? That person may come to the that normal activity. He can able to do all the activities in independent life because the cytokinin level is good. In the active person,
so
compared to the sedentary person. The opioid system also good.
Recent research evidence says that active person versus sedentary population, they are checking the blood level, CRP, ESR, tumor necrosis factor, interleukins and everything. The people who have sedentary, their IL level, tumor necrosis factor, CRP, ESR, everything is elevated compared to the active lifestyle persons. Beautiful point.
Similarly, one more study conducted by Chad Cook in which exercise versus manual therapy, the same cytokine profile was analyzed. In that, exercise has more anti-inflammatory cytokines related things and all get elevated when compared to the manual therapy kind of thing. So it is always, exercise is far better than manual therapy in this kind of thing also. Even though the person is likely to go to the physio. They when they start with the manual therapy, there is no improvement in the cytokine profile levels, so they won't get better. But when they do exercise, the cytokine profile will improve, their anti-inflammatory mediators will be better, then he will be fine.
If a patient comes with pain or any injury or some kind of trauma, they will have some sort of tissue damage or structural damage. Not always, but in some cases they have tissue damage or structural damage. In that case, what how exercise helps is we can give movements or exercises, movement-based exercises, so that the new tissues is formed, and that needs to adapt to the load which is causing the pain. We need to treat the aggravating factor. So we need to give graded exposure kind of exercise to load the tissue continuously. In such case, we'll also improve the patient's tolerance and also improve their tissue loading capacity, which helps them to move better and meet their functional demands.
And also we are training through central and peripheral nervous system. We're not passively doing something. Very good.
So I have one doubt, as you asked. If you're having tissue damage, you are actually healing the tissue by exercise, like what you said. So, for example, usually everyone will have pain when it comes to osteoarthritis.
Okay.
They're having tissue damage in the they're having damage in the articular cartilage. So, if we give exercise, a physiotherapist and patients, everyone will think like we are actually aggravating the problem. We are again and again damaging the articular tissue. But here, we people are giving exercise to the osteoarthritis patients.
Yeah.
So I'll have just have a controversy here.
Yeah, but
So-
what I feel is it's not about the osteoarthritis alone. We need to check for the muscle strength also. Muscle is the first line of contact in our body. So we need to strengthen our muscles so that we don't load our the load doesn't go to the bones directly.
So recent paper, I forgot the paper name, sorry. People who have osteoarthritis, 43% of the people doesn't have pain.
It will be asymptomatic.
Asymptomatic after having osteoarthritis too, just because of they have potential muscle mass and muscle strength. Just because of, basically, if you have a proper muscle strength and the muscle pull bone to another bone, so it protect the joint from the compressive force. So your functionality will get better. As she said, your self-efficacy will be better. So you will not feel the pain even though there's a damage. We can protect. But what was the treatment approach for osteoarthritis? Very simple. Again, you are checking the patient's self-efficacy and attitude and everything. Pain tolerance, adherence, behavior, character, everything you're checking. The grade 4 osteoarthritis. Person grade 4 osteoarthritis, the person high self-efficacy, less amount of pain, still they can manage to do all the things. What I suggested to them, I will try to postpone the surgery as long as possible to you. Same grade 4 osteoarthritis patient comes to us and having a low pain self-efficacy, high pain intensity, and couldn't able to manage, go for surgery, come back, I'll do the same thing to improve muscle strength and pain self-efficacy. I'll make you better. Simple. So grade 1, I won't go that way. Definitely I'll start with the rehab aspect. So grade 2, grade 3 determine whether patient self-efficacy, attitude, confidence, positive behavior response, previous physical activity, lifestyle factor, everything. And body weight when it comes to osteoarthritis. So this is how we have to take decisions. But we have seen people with grade 4 osteoarthritis getting better and postponed the surgery. We have seen people with grade 2 osteoarthritis did surgery. So it's not about the osteoarthritis, it's all about the person who attached to it. It's not about the osteoarthritis caused pain. Yes. It's all about the person who attached to it.
And I also feel confidence plays a major role more than self-efficacy, I guess.
Excellent.
The confidence of the patient directly is proportional to the outcome of the treatment.
Excellent. And confidence of the therapist also directly proportional to the outcome of the... Because therapist confidence also plays major. Recently when I'm taking class from many areas, what orthopedician saying, we are believing. What patient saying, we are believing. We are not ready to counteract and understand and ask questions to assess and treat. That's where the thing is going negatively also. Confident of the therapist as well as confident of the patient is directly proportional to the outcome of the treatment. We are worried, we don't have confidence. What if that increases the pain, what if that happens? Because we never tried movement in our body first of all. We do our exercise on our body, you feel the improvement of walking, you can walk more. You can cycle with very comfortably, you feel lighter. You can play some sports. You can involve in certain activity. If someone felt on, you can lift with confidently. Some rice bag, you want to 25 kg rice bag when you're home, there is functional demand, you can lift by yourself. Those are all the positive benefits you will get. I always ask, one person can't able to bend forward and touch the toes, one person can able to completely touch the toes. Okay, who's having high chance of getting back pain? The decreased range of motion. Here I'm not saying that the person who can able to touch the toe comfortably, they will not get back pain. When it comes to risk factor, who can't able to touch, there is a risk of getting back pain is high. Again, if you have a good adherence, self-efficacy before itself, resilience to that movement before itself, then you can tolerate the problem very easily. So develop that, or else after having a pain, come here and develop that by doing the movement. By doing passive option, we are not improving that aspect. We are again working on it. Pain, only eliminating the pain. And when the person moves again, pain will come back again.
Yes, of course, because all the chronic pain started from an acute stage only. Because we didn't treat the movement properly in the acute stage.
Yeah, we treated only pain.
Yeah.
And when they move, it causes.
So now it became a chronic one.
Exactly. Recurrent
Okay.
pain, recurrent repeated pain. So
Yeah.
started avoiding that movement. Movement avoidance started developing.
Yeah, when it comes to pain, right? So we should just I just have add 3 points. First, we have to understand the movement. The patient should understand the movement first.
Patient should understand the
Yeah,
movement.
yeah. Then the patient should feel safe to do the movement.
Patient should
Feel
safe.
safe to do the movement,
Okay.
and they should experience the movement.
They should experience the moment. One point I would like to add.
Yeah,
here.
okay.
Therapist should understand the patient understanding of the pain. Therapist should
Yes,
understand
yes.
the patient understanding of the pain. Patient should understand these things.
Yes.
Very good.
So by understanding and feeling it safe and experiencing it, will avoid the pain much better.
When we miss that acute stage, the long period of time it takes, maybe a lot of therapists goes on, when lot of doctors they have seen. So when it's come to the prolonged period, in chronic stage it changes. But not only the tissue damage is, we in chronic stage not only we treating the tissue damage only, and also the what are they experience in the meantime of the period they got, and also the same problem in their relatives also they got. They did surgery, and also more number of doctors they said visited.
More number of MRI.
Yeah, MRI.
More number
You
of
need to
visits.
we have to answer for all those things also. So that is so not in the acute stage and chronic stage, not in the same treatment protocol. We have to more focus on biopsychosocial model and the chronic
As
stage
soon
of
as
the.
one pain is become a chronic, psychosocial part comes into play.
Yeah.
As much as its duration of the chronic increases, as much as the biological to psychosocial comes into play. Great. But people will not think that's biopsychosocial. The patient who has pain, they think only biomechanical, which is recurrently causing me pain.
It is also therapist duty to understand the condition and understand the patient. We should not look them as a patient. Instead, we should look them as a person.
Human. Like us.
Human associated with the pain.
Excellent.
Instead of looking onto the pathology or what causes the problem, just look the individual as a whole and look onto his psychosocial factors, what he believes,
Previous physical activity.
everything.
Plays crucial role when you prescribe exercise.
It is our duty to look onto that everything.
Okay. Well, how to prescribe exercise or movements?
And coming to the dosage means, so either we have rule of 10 method. So it is basically like based on VAS score, we give the intensity of the exercise. Okay, like if we have a 7 out of 10 pain, we need to give the exercise
Use 3 out of 10 RPE.
RPE, like that.
Intensity of the exercise is indirectly proportional
Proportional
to
to
the pain intensity.
Yes, we need to measure each activity's RPE.
RPE.
And then we
should
need to-
ask, we should
we
involve
should-
the patient. It is not like 1 hour you can handle 4 patients and
Okay.
single therapist.
And then when it comes to the sets and reps, we can't determine that one.
Excellent. It's not 3 into 10.
Yeah, it is basically a trial and error one.
Beautiful.
It is a grey area.
Prescribe exercise, the trial and error.
It is a gray area. We need to give the exercises, give the number of sets, number of reps, and we need to monitor the patient's response.
Beautiful.
Then only we came to know whether they have higher pain or lower pain. It is same pain. Then we can slowly, if it was acceptable level, we can continue the same. If it was too much, we need to reduce it. Like that, we need to prescribe
So
it.
basically, during the session only, we'll get to know what was the exercise prescription to the patient.
Yes.
Until if you make them perform, we won't know. Somebody can perform first rep 8 repetition comfortably, second set 4 repetition comfortably. May not need to go for third set for them.
Yes.
Somebody, so it's not always 3 with an excellent valid point.
And apart from the prescription, if you are giving any exercise, the exercise must have relevant to that problem. If the person is having any pain while descending the stairs, so while descending, the main muscle quadriceps will go for eccentric. So you should give some eccentric exercise.
Exactly.
So like that, if you are selecting the exercise, it should be relevant to that problem.
Functional demand of the
Yes.
patient.
Then second, the patient should enjoy while doing the exercise. They won't feel like I am patient, I am having some problem, so I am doing this. So don't make the patient like feel like
So here the
patient.
communication comes into play.
Yes.
Make them understand about the problem comes into play.
Yes. If
Why
they
I'm giving this movement comes into play.
Yes. So the patient should enjoy while doing that movement or exercise. And the exercise or the movement you are giving, it should be meaningful. So the exercise will be meaningful to the patient. So if you
What is meaningful to the patient? What is the word of meaningful?
The thing is, I'll say the same example. She said that the descending stairs is a painful thing. So, if you are performing an eccentric exercise for quadriceps, we should make the patient feel that. So, look, the same muscle will work on stepping down. So, we are working on the same muscle. So, rather than we are doing any concentric activity, so why we are doing this activity particularly for you? That is called a meaningful.
Rather giving exercise, we have to give the exercise meaningfully to the patient.
Yes. So make the patient understand also.
Understand them.
Yeah. Then we have to reassess again. So how was your stair climbing now? How is it? How many steps?
Building the tolerance of the tissue.
Yes, exactly.
Improving the resilience through the meaningful way of the functional demand of the patient.
Yes.
Great.
So the exercise should be meaningful, and also we must apply some practical application. After doing exercise, if the person having severe pain while lifting some object, so you are asking the patient to do deadlift something, but the patient previous experiences while lifting the child, they will get pain. But if you are asking the patient to do deadlift, they won't get pain. But again, they'll lift the child, they feel pain. But same lifting movement only, but they will feel pain. So
if here we make that is a meaningful to the patient, they will not
Yes.
get pain. Well, lifting the
yes.
stairs.
So it is not always about what exercise you are giving, what exercise you are doing. It's all about how you use that exercise
Beautiful.
to the patient.
Beautiful. So when it comes to important point nowadays, so we are skillful to prescribing exercise. Physiotherapists are eligible and skillful to prescribe exercise. So who have a higher quality, higher skills set, they have a higher value in the society. So skill set determines your value. Considering that point, IFT, TENS, passive option, anyone can apply. If you teach, no need of specific skill set. But while prescribing exercise to the person, you need a specific skill set. That's why the value of prescribing is more. But nowadays, what the people are doing, prescribing exercise in a social media, 1 or 2 exercises to solve the problem, and secondly, prescribing exercise as a home program. In front of my eyes, as Surendra said, in front of my eyes, I make the person to perform, and then only I know the compensation point, how much they can do, how can they perform. But in your session, you are making the person to lie on the bed, put all the passive option, and send them with the home program. How you trust the patient's movement very clearly. Okay, so what is your opinion about a home program? Giving the patient's home program.
Home program can be given, but in the first place, the patient needs to understand the movement. The therapist should be confident that he can perform that movement without any compensation. Comfortably.
Without any
discomfort. For that, maybe 1 or twice, 2 times he could perform the same exercise in 2
In
to
front
3
of the
sessions
therapist,
in front of the therapist, and then we can prescribe them.
Once the therapist gets confident, the person can perform this perfectly, or the meaningful of the movement, if that patient understand, then we can prescribe.
Yeah, exactly.
So basically, how long, anyone want to add any point of home program prescription? So basically, how many days per week we should treat the patient or exercise or give movement? Take some examples of conditions. Osteoarthritis, disc issue, anything you can.
Weekly 3 days is actually sufficient. No need to make them to come for all days, all the 7 days. All the 7 days you need to do
If
exercise.
you're
It's
treating
not.
pain, you have to make him come all the 7 days. If you're treating the problem, you don't need to make him come for all the 7 days.
Yes. If you are treating them as a person, 3 days is sufficient.
Sufficient.
But it is highly, we need to check other factors, their financial ability. They can come to you for the 3 days.
Yeah.
If they couldn't able to come for weekly 3 days, then here
One or
you
two
have
days
to
itself
apply.
enough.
Yes, 1 or 2 days itself you need to give the quality, qualified treatment. And in that situation, you can add more home program.
So what could be the home program usually when you're treating the patient for 3 days? Other 3 days, what they should do?
Maybe we can concentrate on cardiovascular fitness, more of walking.
So encourage them to go for a
for a
walk,
walk,
and
yeah.
achieve some 7, 8 to 10,000 steps.
Then they can monitor their sleep cycle.
Having a good sleep promote more recovery.
Then we can also ask about what is the nutrition value, what is the nutrition intake you are having daily. So that can be monitored in the other
Sufficient
days.
amount of protein, fibers,
Yeah.
non-processed foods.
Yes,
which
we can
are-
educate like that,
So
those
basically,
things.
my personal opinion is eating food twice a day is more than enough. With the physical activity and lifestyle current generation which we have, twice a day is more than enough.
No, if
Have
the
a good
two
meal.
meal have good calorie intake,
Exactly.
all protein fibers, means that's more
Two
than
meals
enough.
more than
Yeah.
enough.
So hydration also plays a major role in pain intensity. If the patient is not drink adequate water, that time the patient feels the pain intensity more when doing the same movement. But when the patient in adequate adequate amount of water intake, that time the pain intensity may be not much different, but definitely there is a 3 or 4 level of changes is there.
Fine. That's
Next
great.
thing we can teach is breathing exercise.
Beautiful. Breathing
Because
exercise at
in
least. Yeah.
in pain patients mostly they use the abnormal breathing pattern. So we need to teach the breathing exercise properly, and we need to give this as a home program.
So breathing exercise plays crucial role. So at least teach breathing exercise. So if don't advise the patient to perform any exercise, basically change their lifestyle through breathing, nutrition, water intake, sleep. I don't know. First year also need.
Cardiovascular,
Ah.
physical activity, steps.
Physical, improving the physical activity. So use these kind of things as a home program. When they come to you, give quality treatment. More than 3 days, the patient can't able to come. Then use the 1 or 2 session which you are doing to educate and meaningful way to what to do, what not to do. Correctly to the patients. Clear.
When we give exercise for the patient with pain, no, the most important what the therapist should know is how to progress and regress the exercise.
How to progress in this?
Yeah, for example, if
No,
deadlift.
1 minute. If you want to know how to progress and regress the exercise, already uploaded our detailed video. You can tap here to watch the full video. Please continue. Just sharing it.
Here I come.
So the thing is, how to progress and regress means if deadlift is a goal of her, if that is the goal of that is the exercise goal what we are
Maybe
having.
we can say specifically bending forward is the goal.
Yeah, bending forward is the goal. So before that, we should know what is the regression. If the patient not even able to bend forward even a mild degree, what is you will do? You will go with simple spinal movements. You should know how to increase the simple spinal movements to them. So the thing is how to regress exercise also we should know, and whatever the patient level is, you should know how to regress advanced level also.
Regression
So
progress
yeah.
is the key when you prescribe exercise.
Yes, exactly.
If you don't know that, don't expect the patient can improve.
Yes. Because if you keep on giving a same exercise, the patient will not be happy with
That
that.
is also maybe the reason for exercise not
Yes.
working in your clinic.
When we are working with a low confident patient, we no need to give over coaching. Like every time when they do movement, stop in between.
Correcting your posture,
Post-
correcting move, quit.
We need to give only positive feedback. Whatever they can, they are performing. In that, we need to progress slowly, and then we need to go gradually. Gradually, in the sense, it also improve your physical capacity as well as your psychological capacity. When we gradually progress the exposure to the movement, they can perform well. For example, if they can't able to bend slow forward, we will make them to do little bit of movement, and we will educate the patient this movement only happening in that exercise.
Little bit of movement like baby seat,
Yes,
current
like
level, and this is what happening in that like.
You have told one point, right? Rule of 10 while prescribing the exercise. So if patient having 7 intensity, so we can give the RPE for 3. So it is 7 plus 3 10. So you have tell rule of 10, but it won't apply for everyone because the pain intensity is highly subjective. We couldn't able to prescribe exercise based on that pain
Exercise
intensity.
intensity also highly subjective here, right? When it comes to both a subjective scale, it depends upon the patient, it works, right?
எனக்கு புரியல எக்ஸசைஸ்
Exercise intensity also highly subjective, depends on the previous physical activity of the patient, right? Past strength improve. So accordingly, it will match, right? Then, if we are meaning that pain self-efficacy, resilience is one of the important factor for inducing the pain means. So high resilient patient may be so less pain. Less resilient patient so high pain.
But here some psychosocial factor also get plays major
Yeah, absolutely
role.
agree. We can't tell that that's the only way to prescribe exercise.
Yes.
Rule of 10. So
Yes,
one,
yes.
of,
One
the
of the
factor to understand
yes.
when you prescribe exercise.
Yes. So before giving exercise, we need to address what is the needs and goal of the patient. They want to improve the strength or they want to do that movement. That is their goal. So we need to give the exercise based on more mobility exercises. We need to make that movement possible. Then if the person want to get stronger, we need to give some strengthening exercise. We need to progress the strengthening exercise. Also, we need to know before giving exercise the goal of the patient, strengthening or mobility betterment or just a pain free. We need to know
Goal
that.
oriented approach is very, very, very important.
Yes.
For some people, ankle sprain people, someone can able to walk, they will satisfied. Someone has to run. Someone has to play football. Someone has to play for Indian team. So depends on the goal, the rehab will be changed. So goal oriented approach is very, very important when you prescribing exercise and treat the aggravating factor. As they say, treat the aggravating factor. Superb.
So I want to share one experience of mine. So if while taking the assessment, the patient says the 7 out of 10 pain I have. So I can't run more than 2 kilometers like that, he said. So after 2 to 3 weeks of program, reassessing the patient. So now only I have, even now also I have 7 out of 10 pain. So that time I'm just asking, now what about your
How long
running?
you can run?
How long you can run? So he said, yeah, I can run more than 3.5 kilometers. So that time the outcome measure, no need. The intensity of the pain, no need.
So
That time the
intensity of the pain
self-efficacy
does not come
outcome measure. When we come, not all patient, we have to also address the self-efficacy of the particular moments what they complained the before while doing the assessment. So that is also need while doing the assessment. So the outcome measure we want to know
So outcome
as a
measure is not
therapist.
always the pain.
Yeah.
The pain is can decrease. or
Yes.
not. So pain is highly subjective. What you perceive with pain is the pain. Just keep that in mind always. Hope we come to end of this discussion. This video might be useful to you. How exercise will help to reduce the pain. You might have this doubt longer period of time in your mind. So please share this video to your physiotherapy friend. Promote more movement oriented treatment that will stick with you for lifelong, whatever the new technique comes goes here and there. So our role is not only to eliminate the pain, our role is to educate the movement and improve the quality of life of the patients. It's everything's determined by the patient needs and demands. So consider it's not about the pain, it's all about the person who attached to it. If you have any questions or doubts, you can drop it in the comment section. In further, if you want to discuss something like this, you can also suggest a topic in the comment section. So happy learning. Cut.